Good morning and welcome to the 11th Annual Pursuit Awards. My name is Julia Hannigsberg, and I'm the President and CEO at Holland Bloorview Kids Rehabilitation Hospital. It's great to have so many of you joining us. I'm going to start today's event with a land acknowledgement. I am acknowledging the land on which we at Holland Bloorview work, research, learn. I'd invite you, as I acknowledge these sacred lands, to think about the lands where you find yourself. In our virtual settings, we may be coming to a meeting like this, an event like this, from anywhere across the world. So think about where you are, the meaning of the lands upon which you are doing your own work, and from which you are joining us as I acknowledge the lands upon which Holland Bloorview sit. These lands have been the site of human activity for millennia. This land is the territory of the Huron-Wendat and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit. The territory is the subject of the Dish with One Spoon Wampum. This covenant is an agreement between the Haudenosaunee Confederacy and the Confederacy of the Ojibwe and allied nations for peaceable stewardship of these lands and these territories around the Great Lakes. Today, the meeting place of Toronto, where I find myself, is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work in this territory today to celebrate extraordinary research on these lands. Why do we do a land acknowledgement? We do a land acknowledgement as a moment of education and as part of activities of truth and reconciliation. As I speak to you on June 1st, the very first day of Indigenous History Month, I want to pause and also acknowledge that this is a week of particular weight and heaviness for many, particularly those among us who have been most personally and deeply affected by Indian residential schools, the genocide, the violence that was those schools until so very recently, the trauma that they still cause, both to those who were immediately subject and for those who are subject to intergenerational trauma. I hope in your own activities of reconciliation that you are reflecting on the meaning of these tragic events that we grieved this week and thinking about the actions you will take as an individual, the needs we have as a collective to make change. These are certainly things that we are thinking about at Holland Bloorview, and I'd urge you to look at the statement we released yesterday to get a sense of some of those things that are meaningful for us and some of the work that we're doing. So, Pursuit Awards. These are the 11th Annual Pursuit Awards, and of course, we would prefer to all be in each other's company as we would with everything else we're doing, but instead, these are the second Pursuit Awards that we're doing in this virtual way, and we're very grateful to be able to meet in this way, because the important thing about Pursuit, of course, is celebration of outstanding early career researchers. And we are so excited to be able to recognize extraordinary work that is happening in the field of childhood disability. Why is this so important to us at Holland Bloorview? In our No Boundaries strategy, we talk about the idea of discover for action. Discover for action means bringing research into the lives of the people who will be most impacted by it. And why is that so important? I'll quote one of our family leaders who said very simply, research is hope. For children and families at Holland Bloorview, across Canada, across the globe, that's what research means. And that's why the work that you do and that we're celebrating today is so very important. I want to acknowledge that today's event would not be possible without the generous contributions of the Holland Bloorview Kids Rehabilitation Hospital Foundation, the Ward family, and of course, the Bloorview Research Institute. Dozens of applications from across today's leading minds across the globe in the field of childhood disability research. Each year, we see amazing strides and leaps forward in this field that we are so passionate about. These students doing this work are forward-thinking, innovative, and challenging the borders of childhood disability research with their amazing ideas. And over the years, we have seen pursuit applicants come from all over the world, places as far-flung as New Zealand, Switzerland, Brazil, and India. I want to congratulate all the finalists for being selected to present your research. We're thankful for your commitment and dedication to furthering childhood disability research and fostering a strong culture of evidence-based research that accelerates knowledge, again, discovery for action, for the most meaningful and healthy futures for all children, youth, and their families. I know today will be meaningful, impactful, exciting, and successful. I now have the pleasure of inviting our Vice President of Research and the Director of the Bloorview Research Institute, Dr. Tom Chow, to come to our virtual podium. Thank you very much and welcome, Tom.
Thank you, Julia. I think Sandra is going to say a few words first, no?
I am. Thanks, Tom. And thank you, Julia. Good morning, everyone. My name is Sandra Hawken, and I'm the president and CEO of the Holland Bloorview Kids Rehabilitation Hospital Foundation. And I'm here today to thank the Ward Family Foundation for their incredible generosity in making today's awards possible. One of the most rewarding parts of my job is working with donors who love Holland Bloorview as much as I do. That certainly has always been the Ward family. Their commitment to achievement in childhood disability research is simply extraordinary. Through the Pursuit Awards and the Ward Summer Students Program, they're nurturing the next generation of leaders that will bring hope to families through research and discovery. It's a time like no other for research at Holland Bloorview. Not only are we conducting this event and much of our research virtually during a pandemic, we're also in the very final phase of our $32 million campaign to grow the Bloorview Research Institute so that this time next year, we'll be able to say we have the highest concentration of childhood disability research anywhere in the world. Donors like the Ward family are the fuel behind the scientific talent we attract and nurture at Holland Bloorview. And I'm excited to see the impact that scientists and students like the group we are hearing from today will have on the future of childhood disability research. On behalf of the Holland Bloorview Foundation, I'd like to congratulate this year's finalists and to share my profound thanks to the Ward family for their continued support and generosity. We're so grateful for your ongoing partnership. Thank you. And now I'll invite Tom to introduce this year's finalists.
Thank you, Sandra. Good morning, everyone. My name is Tom Chow. Almost forgot my own name there. And I'm the Vice President of Research at Holland Bloorview. And we're so fortunate to have two CEOs, Sandra and Julia, who are so supportive of scientific discoveries at Holland Bloorview. It's hard to believe, but today marks the 11th annual Pursuit Award ceremony. And it's my pleasure to welcome all of you and to celebrate the leaders in childhood disability research. I'd like to echo Sandra's thanks to the Ward family for continuing to support excellence in childhood disability through the Pursuit Awards and our Ward Summer Student Program. Your commitment to helping unlock a world of possibilities for all children with disabilities is truly extraordinary. Opportunities such as the Pursuit Award are crucial to creating efforts to improve the lives of children with disabilities across the globe. Some of the leading young minds apply to this prestigious award every year, showcasing their research and establishing greater developments in this field. And with the final phase of the hospital's research expansion, which you heard from Sandra, we will be able to recruit from a greater talent pool with these Pursuit Awards, and also build capacity and the latest research technology to make even greater impact in the lives of children and families living with disabilities. Thanks to the generosity of our donors, once completed next summer, we will have the highest concentration of childhood disability research in the world. This means, among other bold initiatives, we can establish our world-class developmental neuroscience program, which includes a fully accessible, child-friendly, accessible MRI suite. We'll also have 9 new discovery hubs where researchers can connect and collaborate on exciting research in areas such as machine learning, music and the arts, neuromodulation, and rapid prototyping. These are all exciting new features of our research institute to help further the field of childhood disability. We'll also accelerate commercialization efforts to bring research innovations to the marketplace so that they can be accessible to families, clinicians, children, and youth. In short, this is such an exciting time for the Research Institute. We've persevered thus far thanks to the ingenuity of our researchers and staff, as well as the ongoing support of all of our donors. I was reading yesterday morning something from Juan de la Cruz, who's a Spaniard from many years ago, and he had a really interesting saying that I wanted to share with you today. And he basically said, where there is no love, put love, and you will find love. And it took me a little bit of reflection to make sense of this very simple statement. But to me, it spoke of the unstoppable potential in all of us to bring out the very best in each other, in spite of personal and global circumstances. Where there is no love, put love, and you will find love. Today's presenters, I think, exemplify what you get when you put your heart into science. So I want to congratulate all of our finalists. Thank you for continuing to advance the field of childhood disability research, and thank you for championing a brighter future for children and youth living with disabilities. And I also want to thank the scientists who took their time to review all of the applications to select our top 3 candidates. It was not an easy task. So I'm sure you're all excited to hear from some of the best emerging minds in childhood disability research. Today, we'll have 3 finalists, and each will give a presentation, and that will be followed by a question and answer period. And if you have a question that you'd like to pose, please use the chat function to submit your question. So our first presenter of the day is Dr. Diane Mcdonald. Diane completed her PhD at the Human Development Program in the Department of Educational and Counseling Psychology at McGill University. She's a part-time instructor at Concordia University, teaching courses on inclusive education and evidence-based practice in the Department of Education Child Studies program. Her research focuses on strength-based interventions that target a child's strength to support challenging areas. Diane's background and continued work as a speech-language pathologist, concentrating on autism spectrum disorders and reading disorders for preschoolers, school-age children, and adults motivates her to study and develop evidence-based practices. Please welcome Diane.
Hello, everyone. My name is Diane Mcdonald, and I am honored to be presenting my research at the annual Pursuit Award competition. Thank you to the Holland Bloorview Foundation, the Ward Family Foundation, and the Bloorview Research Institute for recognizing my research. The title of my thesis is Understanding Emergent Literacy and Improving Reading Comprehension of Preschool Children with Autism Spectrum Disorder and Hyperlexia. I want to start by asking you to read some words. Brabium, umble, snood. I'm sure you could all read these words as I just did, but I bet most of you don't understand their meaning, and that's intentional. You've just experienced hyperlexia. Hyperlexia is a reading comprehension disorder accompanied by a strength in advanced early word reading, and it's most commonly associated with autism spectrum disorder. There were 2 major questions that drove my research in hyperlexia. First, how do preschoolers with autism and hyperlexia learn to read at such an early age, as young as 2 years old? More specifically, are they learning to read in the same way as typically developing children? And how can preschoolers with autism and hyperlexia learn to understand what they read? For both these studies, I recruited 30 participants from Montreal and Ottawa, 15 with autism and 15 with typical development. They were all between the ages of 3 and 5 years, 11 months. They spoke English at home. They had an interest in letters, words, or could read. They had no history of formal reading instruction, and they all had normal hearing. Within the group of children with autism, they were further divided into those with hyperlexia who met the 5 criteria according to Needleman, and the remainder were assigned to the group without hyperlexia. My first study, entitled Early Word Reading of Preschoolers with Autism with and Without Hyperlexia Compared to Typically Developing Preschoolers, was published in the Journal of Autism and Developmental Disorders in August 2020. And this was the first study to look at an exclusive group of preschoolers with a sample size larger than 2. I'll just briefly discuss this study and then spend more time on study 2. In this study, I compared emergent literacy skills of phonological awareness, phoneme-grapheme correspondence, and letter naming of preschoolers with autism and hyperlexia to 2 control groups, the typically developing group and the group with autism without hyperlexia. According to the National Literacy Panel, for typically developing children, these are the 3 emergent literacy skills that are prerequisites to reading that develop before children start reading accurately and efficiently. Phonological awareness is the ability to manipulate sounds in spoken words. To think about phonological awareness, think Dr. Seuss. So rhyming, segmenting syllables like separating cupcake into 2 words, cup and cake, or identifying sounds like cat and can and cap. I'll start with the k sound. This was found to be a challenge for preschoolers with hyperlexia, in agreement with 2 other studies where one had a small sample size and the other mixed participants of preschoolers and older children. As children are exposed to print, they develop phoneme-grapheme correspondence, that is the ability to assign the sound to a letter. For example, B says ba. And this was found to be a challenge for preschoolers with hyperlexia, similar to a previous study with a small sample size. And finally, letter naming is the ability to name the letters of the alphabet. And this was the only emergent literacy skill set found to be a strength. So thus the results are in agreement with previous studies of smaller sample sizes or those mixed with older children, indicating that preschoolers with hyperlexia are not following the same pathway to reading as typically developing children and are thus following their own unique path. The next steps will be to examine exactly what this unique pathway is. My second study, entitled Early Reading Comprehension Intervention for Preschoolers with Autism Spectrum Disorder and Hyperlexia, was accepted for publication in the Journal of Autism and Developmental Disorders just last month and focuses on helping preschoolers with autism and hyperlexia improve their reading comprehension. And to that end, I created a parent-supported tablet-based application that targets reading comprehension at the most basic level, word picture matching. This intervention is based on the simple view of reading that states that the product of word reading and listening comprehension equals reading comprehension. As applied to children with hyperlexia, these children have strong word reading, but weak listening comprehension that leads to weak reading comprehension. And therefore, according to this model, to improve reading comprehension, we need to focus on listening comprehension. And in order to do that, this is based on the dual coding theory that states that the image plus orthography, or the written word, leads to increased receptive vocabulary acquisition. So if we think back to these words, brabium, umble, and snood, to understand them better, we can pair them with their image, brabium to prize, umble to flower, and snood to hairnet, and you've just increased your receptive vocabulary. Here's an image from my intervention app. There are 2 phases of this app. This is the listening comprehension phase, where the child both hears the word spoken and sees the written word simultaneously, and then touches the correct image. Once they've acquired the word at the listening comprehension phase, they're then exposed to the reading comprehension phase with the same word. And now they only see the word and then match it to the correct image. The intervention advances in complexity to phrases and then sentences. This study was a repeated measures A/B design, and all children and their parents were evaluated at time 1 prior to a 6-week no intervention period, where parents were asked to do what they normally do at home with their child. The no intervention period was to control for and compare to normal developmental growth. At time 2, only the children were again seen for assessment prior to the intervention period, where parents were asked to support their child's use of the tablet intervention at home for 5 days a week, 15 minutes per day over a 6-week period. And to use the tablet intervention as they would a book, like by commenting on pictures, sharing experiences. All children were finally reassessed at the end of the intervention period at time 3. I assessed reading comprehension, listening comprehension, and expressive language using standardized measures at the 3 time points. Here's the results for reading comprehension. Although there were no significant differences among the groups for reading comprehension at time 1, there was a significant increase in reading comprehension scores post-intervention from time 2 to time 3 for the hyperlexic group here in orange. These results indicate that the scores on reading comprehension were significantly higher following the intervention period for the group with hyperlexia. For listening comprehension, there was a significant improvement in listening comprehension scores from time 2 to 3 for all groups taken together, but not for time 1 to 2, which was a no intervention period. This indicates that listening comprehension scores were higher after the intervention as compared to before the intervention. And finally, for expressive language, we found there were no significant improvements in expressive language. So I won't show you that graph. This novel tablet-based parent-supported reading comprehension intervention demonstrated improvements in reading comprehension scores for the group with hyperlexia and listening comprehension scores for all groups taken together, but had no effect on expressive language scores. If we look back at the simple view of reading model, the group with hyperlexia we know has strong word reading skills, but now post-intervention, they demonstrate improvements in listening comprehension that lead to improvements in reading comprehension. This is the first study with the largest sample size to clarify the early word reading profile or emergent literacy profile of preschoolers with autism and hyperlexia as different from TD children. So this study provides a greater understanding that helps to develop best practices and potentially shape policy to appropriately target their specific learning needs at home and in the classroom. This was also the first reading comprehension intervention to begin at the preschool level that improves both reading comprehension and listening comprehension. This represents a paradigm shift in teaching reading comprehension because typically reading comprehension is targeted in grade 3 or later. And although my sample size was small, the results are encouraging and suggest we should be teaching reading comprehension earlier at the first signs of hyperlexia. Parents were able to successfully deliver this intervention at home, which means it can be used as a valuable stopgap while awaiting public services. And this strength-based intervention shows that targeting a child's strength to improve areas of challenge is a successful model upon which to base future interventions. And finally, it was encouraging to see that the benefits of this intervention extended beyond the group with hyperlexia to those with and without exceptionalities. Thank you to everyone who supported my research, especially the parents and their wonderful children. And thank you for listening.
Thank you, Diane. Excellent presentation. Just remind the audience, if you have questions, please enter them in the chat and I will read them out. So the first question I have here, Diane, is that some people believe that hyperlexia is part of the normal variation in reading skills, and maybe with development and over time, some of these delayed comprehension will resolve. I wonder what your opinion on that perspective might be.
Yes, thank you. That's a great question. Reading comprehension is a challenge is typically viewed as one of the biggest academic challenges for children with autism. And so I don't see that it just resolves. I think that even for children who don't have hyperlexia, children with autism who don't have hyperlexia, there's still challenges for reading comprehension. And so there's a lot of interventions that begin, a lot of research that target reading comprehension in the later grades. And so I think my feeling is that even for children without hyperlexia, I think we should be starting earlier to target reading comprehension earlier than, middle primary grades to help with academic success and, social interactions. And there's a lot of, learning that comes with reading comprehension, and so it's integral. And yeah, I would feel strongly that earlier intervention is better.
Thank you, Diane. Another question here. An elegant summary of an impressive body of work. That's a comment. Could you please explain how children on the spectrum with hyperlexia were defined in your study if they did not present with lesser listening comprehension at baseline? I hope that makes sense.
Yeah, I didn't go into, there were 5 criteria that defined hyperlexia, and poor listening comprehension was one of them. So their listening comprehension was assessed on the Weschler preschool assessment, and their verbal comprehension scores were used as a measure, and that certain criteria, they were all below a score of, I think it was 78. So they all started off with a very weak listening comprehension. And even there was another measure we used pre and post intervention, which was the OWLS, which was more visually based. So it had pictures, and it was just pointing to task, because the WIPSI sometimes has been criticized when it's used with children with autism because it's very language based and there aren't a lot of images. So we also use the oral and written language scales, and there were also lower on that scale, and their receptive vocabulary, which was also assessed on the WIPSI, was lower as well between the 2 other, as compared to the 2 other groups. So they did start off with lower listening comprehension. I'm sorry if I wasn't clear about that. I hope that answers the question.
Okay, thank you. I'm just seeing a message here. Is it time to move on? Well, one more question. Okay, one more quick question. The strengths-based aspect of your intervention, is it the focus on the perceptual expertise, like exploiting the enhanced perceptual expertise of the child? Is that the intent of the tablet-based intervention?
Well, the strength-based is really their advanced early word reading skills, and it's not really clear if I believe that is what it taps into, is the enhanced perceptual abilities. But it was really the strength in word decoding, and then pairing it with image to try and improve their reading comprehension. So one of the reasons why, when we looked at why they might be reading at such an early age, there's the enhanced perceptual functioning theory that states that their enhanced perceptual abilities in combination with repeated exposure to the words allows them to identify patterns in the orthography in the written language, and that could be how they're actually teaching themselves to read. And so that's an exciting next potentially avenue to pursue, is looking if that's actually, how they're reading at such an early age. But yes, that's definitely enhanced perception. And then there's hypersystemizing, that need to find regularity and order in the world, and so that again relates to maybe potentially pattern recognition. And so that's one of the possible strengths that I think is tapped into in this early reading ability.
Thank you so much, Diane. I'm getting a warning that I'm entertaining too many questions. Okay. Clearly a very interesting topic.
Thank you so much.
Thank you so much, Diane. Now I'd like to move on to our next finalist, Dr. Victoria Sherman. So, oops, just lost my screen there. So Victoria is a speech language pathologist, as she completed her PhD in rehab sciences at the University of Toronto. Her clinical work guided her pursuit of research in stroke and dysphagia. She focused on bridging the gap in dysphagia practices between adult and pediatric stroke. Her research goals include early detection, standardized assessment protocols, and early intervention of dysphagia to improve patient care and health outcomes in the young stroke groups. Victoria hopes to continue her research program as a clinician scientist, but is currently focusing on caring for her baby who was born in April. So congratulations. Welcome, Victoria.
Hi, my name is Victoria Sherman, and today I will present on my doctoral research entitled Early Identification of Dysphagia Post-Pediatric Ischemic Stroke. Stroke is a leading cause of death across the lifespan and is in fact one of the top 10 causes of mortality in children. In children, stroke can happen anytime from 28 weeks gestation onwards up until 18 years, considered neonatal stroke within that first month of life and childhood stroke beyond. Ischemic stroke in children includes arterial ischemic stroke and cerebral sinovenous thrombosis, and is distinct from adults with regards to acute clinical presentation, risk factors, etiology, and short and long-term outcomes. And perinatal arterial ischemic stroke is a leading cause of hemiplegic cerebral palsy. There's been significant progress in understanding outcomes of pediatric stroke in the last 2 decades, with known outcomes to include cognitive, motor, and behavioral, for example. However, there has been limited work to date exploring speech pathology-related outcomes in pediatric stroke, including sensory motor outcomes like dysphagia. In adults, we know that there's a large proportion of patients with dysphagia, dysarthria, and aphasia, so swallowing difficulties, motor speech, and language impairment post-stroke. And these outcomes are known to coexist and can adversely affect short and long-term outcomes. In adults, the current practice for dysphagia is well established. It first begins with a bedside screening by a trained health professional, which identifies risk and initiates the necessary referrals to dysphagia experts for further assessment. Dysphagia practice is outlined in many stroke practice guidelines, including Canadian and American, and they endorse screening as a critical first step to early identification of dysphagia. There is still some work to be done in adults. Even though screening is currently recommended in guidelines, there has been inconsistency over the past decade, leaving the healthcare professional questioning the true health benefit. In children, there are no practice guidelines specifically guiding dysphagia practice post-stroke. And this leaves us questioning if there's no systematic identification of dysphagia early, no initial step of screening, are their kids being missed? So the aims of my doctoral research were to derive the benefit of dysphagia screening in adult stroke, improve our understanding of incidence and current assessment practices in pediatric stroke and dysphagia, first in the current published literature, and secondly within a single institution, and lastly to inform the development of a reliable and accurate pediatric dysphagia screening tool. We first asked, does dysphagia screening to stroke patients by a non-dysphagia expert reduce health-related complications compared to similar patients with no or relatively less rigorous early detection in adults? Following a Cochrane protocol, we identified 33 articles, 30 of which were unique, with different screening comparison groups. For example, no screening versus screening, late versus early, and informal versus formal. We found a significant protective health benefit. For our 4 outcomes, pneumonia, mortality, dependency, and length of hospital stay, across study types and groupings, the overall pooled estimates favored the experimental screening groups for all 4. As you can see, the pooled estimate on the left of the midline for pneumonia, mortality, dependency, and length of hospital stay. This benefit was consistently realized in that late versus early subgroup, showing that an earlier screen had a benefit on health. So given the differences between adult and pediatric stroke, we cannot assume that what is well known in adults applies to children. So through conduct of a systematic review, we asked, what is the reported incidence of dysphagia in the pediatric patient population with acute stroke or hemiplegic cerebral palsy? And of those, what is the reported incidence of poor health outcomes and caregiver burden? Again, Cochrane methodology was closely followed, yielding 5 articles, only 3 on stroke and 2 on hemiplegic cerebral palsy. And we found variable reported frequencies. So across the 3 stroke studies, one found dysphagia in 48.8% of their symptomatic neonatal population. One identified swallowing impairment in 88.6% of their childhood stroke group. And one identified feeding difficulties in 24% of their neonatal stroke group. No dysphagia assessment protocols were described across these 3. Of the 2 hemiplegic cerebral palsy studies, Moraro and colleagues used the Dysphagia Disorder Survey and the Dysphagia Management Staging Scale, which is validated on individuals with developmental disabilities. And they identified mild dysphagia in 50% of their group. And the final study identified swallowing impairment in 35% of their group. Only Barkat-Messi and colleagues reported health outcomes and none reported caregiver burden. So realizing the paucity of evidence on dysphagia, we sought to explore this outcome further at our own center through retrospective chart review and database analysis over a 5-year period. We asked, what is the reported frequency of dysphagia? And we expanded to include oral motor dysfunction, motor speech and language impairment. What is the co-occurrence and potential predictors of these target impairments? And what is the reported frequency of caregiver burden? We stratified our analysis by age in keeping with practice, and we had 67 neonates. We identified how many patients received notations and assessments for each impairment. Notation was defined as any note by any health professional which could indicate potential presence or absence prior to the assessment by an expert. We looked at time from admission to first notation and assessment, and we found relatively timely mention. So for example, from admission to dysphagia notation, there was a median of 75 hours. We found swallowing impairment in 38.8%, feeding alone in 16.4%, and oral motor in 6%. Dysphagia, defined as feeding and or swallowing impairment, was also in 38.8%. And caregiver burden was identified in over 60% of neonates and their families. We had 106 children, and again, top left, you can see the notation and assessment counts. So for example, 69% of children had a note on dysphagia and 55.7% received an assessment. We captured timing again for each impairment, which continued to show relatively timely capture. So for example, there was a notation on dysphagia within a median of 24 hours. We identified dysphagia in 40.6%, oral motor also in 40.6%, motor speech in 36.8%, and language in 31.1%. We found arterial ischemic stroke subtype as compared to cerebral sinovenous thrombosis and stroke severity to be associated with each target impairment, and caregiver burden was identified in over 50% of children and their families. Although we identified attentive informal surveillance with relatively timely capture, there was no initial formal screening step and no formal protocols used to identify and assess dysphagia. And again, this leaves us questioning potentially that patients are being missed, and also left us questioning, are these frequencies potentially even conservative? Now knowing the significant benefits of early identification in adult stroke, this led us to believe similar benefit could be realized in children. And this led me to my final dissertation study, which was to complete the initial steps to develop a standardized dysphagia screening tool. We asked, what are dysphagia assessment items endorsed by clinician experts to be included in the development and validation of this tool? This was a two-phase study with item generation followed by item reduction. We generated an exhaustive list of all potential dysphagia assessment items from the literature and expert consultation, and we created a conceptual map to categorize these items. These were then populated into a survey format with questions regarding relevance and feasibility, and we included extra questions to guide whether swallowing trials should be administered in the screen. We had 57 complete responses from speech-language pathologists across the world who all worked across the pediatric age range in different settings. And based on survey responses, we ran item content validity indices to identify those items rated as the most relevant and feasible. An ICVI greater than or equal to 0.78 was deemed to keep, and we found 4 items, which included facial symmetry, salivary control, level of alertness, and choking. We identified clinical uncertainty on whether swallowing trials should be administered. 31 respondents endorsed administration of swallowing trials in the screen, of which 25 endorsed thin liquids, most commonly recommended by teaspoon or open cup. We conducted chi-square analysis to explore any differences in the endorsement of these swallowing trials across country, years of experience, and proportion of caseload, and we found no significant differences. So there remains the need for prospective administration for clinical feasibility, inter-rater reliability, and accuracy. So in summary, our meta-analysis confirmed a benefit of dysphagia in adult stroke. Our systematic review identified 3 studies on pediatric stroke and dysphagia with limited details on definition and assessment. Our database and chart review found that these target impairments existed in 30 to 40% of all pediatric stroke patients in the acute phase and were often overlapping. And our prospective survey identified dysphagia assessment items deemed relevant and feasible to move forward in the development of this tool. My overall vision is to build capacity within pediatric stroke and speech-language pathology with goals to improve early recognition, develop standardized assessment protocols to initiate early intervention, all with the overall goal to improve patient care and health outcomes for this unique young patient group. Some of my short-term goals include to assess the psychometric properties to continue the validation of this dysphagia screening tool, characterize short and long-term burden of dysphagia, and determine neuroanatomical predictors of impairments. Thank you very much for listening, and a huge thank you to my supervisory committee and for the clinical and research teams that helped to make this research possible throughout my PhD. Thank you.
Thank you, Victoria. An excellent presentation. Just remind folks to enter your questions in the chat. So thank you, Victoria. Maybe we'll just start with one question. What's based on what the the literature that you've looked at, what would be the your first advice to families with neonates in terms of enhancing their vigilance for potential swallowing difficulties? What should they be looking for? Is it breathing, changes in breathing, coughing? What would your advice be?
That's actually a really tough question, because what I've found is so many tools that exist already to identify swallowing problems are based on caregiver report. And part of what's unique in this is when a new event happens, like a new stroke, it may be hard for the family to pick up on subtle indicators that there is a problem. So the unique aspect of this tool is that it would be administered in the hospital by a trained health professional to kind of pick up on those subtle cues. But for sure, there are some indicators that leading experts in our field have kind of brought forth for families to look for, such as like the length of the feeding, breathing, like you said, choking, anything that might be indicating potential impairment there. But good question.
And just one more quick question: the severity of dysphagia that you observed in the literature, are these children who are aspirating, or there's less severe?
Yeah, so that is something that I'd want to explore further, because this is really like dysphagia and pediatric stroke really has been understudied. This is kind of the first literature review and then kind of database and chart review that we've done. It would be super interesting to look forward at actual severity of dysphagia. We suspect that, more severe stroke or more severe dysphagia, as well as arterial ischemic stroke versus the cerebral sinovenous thrombosis type of stroke, which is an event in the vein versus artery. So an event in the artery would show some more severe swallowing problems as well. But again, those are kind of exploratory questions for us to move forward. Yeah.
Great. Thank you very much, Victoria. Such an important area of work, something very close to my own heart, actually. I worked in this area for a number of years myself early in my career. So thank you very much. And we'll now move on to our third finalist for this morning. So our final Pursuit Award nominee is Dr. Kern Hertubis. Karen completed her doctoral studies in health science research at the University of Sherbrooke. She's currently a postdoctoral fellow at the School of Rehab at the University of Sherbrooke with a focus on parent coaching approaches to pediatric rehab in telehealth. Her clinical research has aimed to better understand the experiences of children, youth, and caregivers with the healthcare system and apply patients and public engagement strategies in co-designing, implementing, and evaluating novel interdisciplinary rehab models to improve service access. She's also leveraging her doctoral study findings in assisting the co-creation of a provincial chronic pain step service for children, youth, and their families in Newfoundland and Labrador. Wow, covered a lot of ground in one doctoral thesis. So please welcome Karen.
Good morning, and thank you for the opportunity to present at the Holland Bloorview Research Institute Pursuit Awards. My name is Kern Hertubis, and I'm a postdoctoral fellow at the University of Sherbrooke. It gives me great pleasure today to share with you some of the findings of my doctoral dissertation. So what if I told you that 1 in 5 of our children has recurrent or persistent pain lasting more than 3 months? Chronic pain in the pediatric population is increasing at alarming rates, a public health emergency that needs to be recognized. If left untreated, pain can cause damage to the body and brains of our children. Pain affects all areas of development. It can create serious limitations in a child's physical functioning, their ability to attend school, and interact with other children. In essence, pain stops kids from being kids. And what if I told you that these consequences extend far beyond the child themselves into their families, our communities, and society? Pediatric chronic pain costs us 16 billion Canadian dollars annually. That's more than childhood obesity and asthma combined. And sadly, The consequences impact family functioning and can result in long-term impacts on a sibling and parent mental health. If left unsupported, kids with pain-related disabilities become adults with pain-related disabilities. In fact, statistics show that 2/3 of these children will become adults with chronic pain. And what if I told you that we don't even know what treatment is most effective? What we do know is that medications alone are not the cure. Multidisciplinary rehabilitation treatments are what is being recommended. Two models exist. The intensive interdisciplinary pain treatment, which although rare in Canada, can be found on some inpatient units, day hospitals, or a combination of both, and the more frequently encountered multimodal outpatient treatment model. However, neither of these have been proven. Program variations have precluded the clear study of their effectiveness and their comparative effectiveness. We have also failed to identify when we should treat these children, who should treat these children, how much and how we should treat these children, where we should treat them. Furthermore, although some treatments have been evaluated, the outcomes have focused on what clinicians and researchers believe are indicators of success. Evaluation research espouses a judgment on value. Sadly, the evaluation of pediatric chronic pain interventions to date has failed to capture the perception of those that receive the treatment. Youth with pain-related disabilities and their parents' voices are absent from this literature. My doctoral study attempted and was able to fill some of these gaps using a participatory evaluation approach and some novel and innovative research methodologies. Here's what we learned. By partnering with youth with pain-related disabilities and their parents, clinicians and physicians that treat them, as well as healthcare administrators, we were able to prioritize 6 outcome domains upon which the evaluation of our multidisciplinary rehabilitation treatments at our facilities would be based. The 6 domains are illustrated here on this slide. Unfortunately, we quickly realized that patient-reported outcomes were only available for 4 of these domains, leaving 2 unmeasurable. This identifies an important measurement gap. Using the available measures, we evaluated the 2 service delivery models available at our facility. Our multimodal outpatient treatment, which is comprised of at least the 3 disciplines identified here on this slide, as well as our more integrated model, that of our intensive day hospital program. What we learned was that our intensive day hospital program was effective both in the short term and in the long term in reducing the interference pain had on youth's ability to perform their activities of daily living. It also proved effective in decreasing in the short term depressive symptoms. However, unfortunately, the benefits were not seen long term. Surprisingly, we also learned that youth participating in our multimodal outpatient treatment tended to report better quality of life at 12 months than those in the intensive program. When interviewed, the participants in our intensive program told us that they had had difficulty transitioning back to real life following the program, resuming peer relationships and friendships, keeping up with schoolwork and school expectations, in particular with graduation looming, learning to self-manage in their new reality, as well as identifying meaningful activities, were all challenges that they faced post-program. This raises important questions around where we should treat these children. Should we remove them from their context or meet them there? It also raises important considerations with regards to when we should treat these children. Are there population characteristics associated with age and academic trajectory, which match better with one service delivery model as compared to the other. And finally, youth with pain-related disabilities and their families also highlighted to us the program components they most valued. These included pain education and learning about pain strategies, peer support for both children and their parents, as well as coaching in context, in the context of their pain, in the context of their family, in the context of their real life. These three components transcend disciplines, which raises important questions about who should treat these children. So where do we go from here? Well, these findings are important to consider when recommending treatment to youth with pain-related disabilities and their families, as well as in developing future programming for this population. However, there are also other key messages that I feel compelled to share with you today. First, youth with pain-related disabilities feel invisible. Invisible in their care, invisible in research, invisible in society. Youth that avail of our services tend to be Caucasian, English speaking, from high socioeconomic status, with married and well-educated parents, and who very rarely have other varying abilities or medical diagnoses. We need to question equity. We also identified an important measurement gap. Instruments to measure what is most important to youth with pain-related disabilities and their parents do not exist. Can we truly establish evidence-based effectiveness without these measures? The services that we provide are located in health facilities that are specialized, typically in urban centers, away from the lives of youth with pain-related disabilities and their families. Is this appropriate access? And finally, we have been led to believe that more treatment is better, regardless of system costs or costs to the family. Is this being accountable? Pain is the most common symptom that brings parents to seek medical attention and advice for their child. Chronic pain is undoubtedly complex and is most certainly a family issue. For youth with pain-related disabilities and their families to have access to compassionate, equitable, evidence-based, and cost-effective services that allow them to enjoy a meaningful and healthy life, courage, resilience, and innovation will be required on our part, on the part of the research and clinical community. The research and practice silos that currently exist, such as those in the fields of childhood disability, childhood pain, as well as pediatric and adult services, need to be broken down. Clinicians and researchers need to commit to partner with youth with pain-related disabilities and their families to identify their needs, ways to measure what is most important to them, to co-create acceptable, feasible, and efficient services, to locate these services where the families can access them when they need them. We need to do better for Canadian children and their families. Thank you. I'd like to acknowledge my thesis supervisors, the leadership team at Alberta Children's Hospital, my lab colleagues, the funding agencies and training programs that supported me during my doctoral studies, the wonderful members of my advisory committee whose wisdom and stewardship helped me bring this project to completion, and most of all, to the participants of this study, the parents and youth who so willingly shared their experiences and allowed me to walk alongside them for part of their journey.
Thank you, Victoria. We have a question that's come in already. It's about whether it's fair to compare outpatient and inpatient participants And what types of pain and medical conditions were the source of these pains in each group? And does that potentially explain the difference between these groups?
So thank you for that question. What I would say is, in fact, it was fair to compare, and a little bit different than some of the other programs, is that in fact we have the way the program at Alberta Children's Hospital in fact functions is that they do not need to fail outpatient services before they're admitted to other services. So in particular, the intensive program. So what happens is that the service is, the child is assessed, decide whether services actually should occur. Either a multimodal program or the intensive program is presented to the family, and the family gets to choose which one would actually be of benefit. Now, some do decide to choose the multimodal program initially, although others have also decided to go straight into the intensive. So there is recommendations provided by the team. However, what I would say is that the families do have that option. Equally, when we looked at our two participants groups, they were quite similar in age, in types of conditions, as well as how long they had the pain and the intensity of the pain. So there was a slight difference with regards to our intensive program, having more patients that had types of pain that such as complex regional pain syndrome. And then there was and the outpatient group was slightly younger, but that's all I would say are the differences that we saw.
Thank you, Karen. One other question here. Can you comment on, and you've mentioned some of this in your talk already, the role of social factors in children's perceptions and reactions to pain, in particular, supports available to the family culture. You've mentioned the economics already, but familial distress and conflict. How do these contribute to a child's perception and reactions to pain, and what types of interventions might therefore be appropriate?
Thank you for that question. In fact, as I mentioned in the talk, the field as well as chronic pain overall is very complex, and family plays a large part in it. So what I would say is we're gaining more and more understanding around some of the familial factors. There's being, through some of the genetic research, we are seeing that as high as 50% of children with chronic pain have parents with chronic pain. Equally, there are very high levels of PTSD in families of children with chronic pain. I'd also draw attention to, if you're asking social contexts, the role of peers and peer understanding related to pain, as well as child's perception of peer understanding, and how that can create some interesting aspects within the pain condition. So children in particular, because they're adolescents in that developmental stage or phase, friends are really important, fitting in is really important, and therefore they don't tend to divulge a lot of their pain conditions. They push through, or they isolate themselves just so they don't have to deal with discussing their pain. They don't feel comfortable, they don't know how to explain it. And then finally, school plays a very important role, and how teachers react. And again, there's been a little bit of research related to that, both from the perspective of how teachers respond, but equally how parents and youth expect them to respond. And sometimes the differences between those expectations causing some interesting interactions. So hopefully that kind of covers that whole social context that does certainly play an important role within the lives of youth with pain-related disabilities. It also, I think, gives us some important avenues of potential areas where we should look at at treatment. So we have involved parents with regards to treatment, but for the most part, it's providing them with parenting advice, not necessarily looking at their own chronic pain or trauma journey, and really going to the crux of some of those aspects. Equally, I think there, and we've started some work around schools informing teachers what is chronic pain, and then what are some of the accommodations they can actually provide for these students, and how they can react, and how to work with the families. And last but not least, really looking at the peer group. How do we reach them? How do we make them understand their friends with chronic pain? How do we help children and youth actually explain their chronic pain? So I think those are all aspects that we can certainly add to our interventions that currently are potentially not there. We focus it very much on the child. And I think what we can learn from the rehab pediatric rehab literature is that we need to go get some of that context, try to change the context to meet some of the child's needs. So I think there's a two-way street there that needs to be developed.
Thank you so much, Karen. No doubt a complex multifactorial issue here. So thank you so much. I understand that you got bonus points because I called you Victoria by accident and you didn't even flinch. So my apologies to both you and Victoria. So thank you very much, Karen. There's a lot of interest in these topics and we could go on. I do have to move on now because of our time limitations. So thank you to all three of our finalists. Next up is our keynote speaker today, which happens to be, and we're very fortunate to have, Dr. Stephanie Snow, who was last year's first place recipient from the Pursuit Awards. She's going to speak with Amy and Macy Spurway, a family who has been an important part of her research involving the creation of better outcomes for children with autism at the time of their surgery. And they're going to talk a little bit about their experience at IWK. So over to Stephanie, Amy, and Macy.
Hi, guys. Hi, Stephanie. It is so great to reconnect with you after, gosh, how many years? 4 or 5 years?
Yeah.
This, and we're so proud to be involved with your research and involved with this project and with you. And it's really great for us to reconnect with Holland Bloorview again, because back when we lived in Toronto in 2003, my twins were born prematurely. And as a result, their development was followed by Holland Bloorview for years. So it's really, really nice to see you again and to be doing this in conjunction with Holland Bloorview.
Yeah, that's so cool. It's such a nice full circle moment. Hey, and Macy, I know we chatted a little bit, but it's so cool to see you. I think you were 8 when we met, right? And now you're like all grown up and here we are. Yeah, I'm really excited for you guys to interview me today.
Yep, really excited too.
Okay.
So Stephanie, can you tell us how you became interested in clinical psychology?
I had the opportunity to do an advanced placement course in psychology. And then that meant that when I got to university, I got to kind of declare my major right away and dive right in. And I saw like an opportunity to be a research assistant in a lab. And I was like, well, that sounds interesting. And I was, part of it was that I struggled with the lack of structure in university, right? It went from having like classes all day to all of a sudden you might only have 6 hours of classes a week. So I was looking for things to do, ended up in a research lab. And I thought at the time, maybe I wanted to do psychiatry, but my mentor in that research lab kind of said, I don't think you want to be a psychiatrist. And he's like, you know, I just think that this might be a better fit for you. Maybe you might want to consider clinical psychology. And I guess I trusted him or something. I don't really know why, but I took it and I ran with it. And I said, sure, let's do that instead. And I think part of it was I was also avoiding doing calculus. And this pathway allowed me to do a Bachelor of Arts instead of a Bachelor of Science. But I'm happy with where I landed. So, yeah.
We're glad you avoided calculus to do this instead.
Yeah.
I would have too. How did you come to work on research to help kids with autism and their families?
Right. Yeah. So, I mean, I guess there's the long version and there's the short version. So after I did my undergrad, I applied to graduate programs. And I guess during my undergrad also, I worked at a summer camp. Part of my role there was to work as a healthcare director and to support kids that came to camp that also had all kinds of different abilities. And a lot of those kids had autism. And I had the opportunity to spend time with them and really, again, just valued that experience and what I was able to kind of learn. And it motivated me to really want to continue spending time working with kids with autism. I knew from them that there were a lot of challenges in the healthcare system and challenges in terms of, you know, resources going to things that would actually make a difference in their day-to-day lives. And so I didn't know quite what that would look like, but I did have that experience that guided me to choose to stay at Dalhousie, which is where I did my undergrad, work with one of my supervisors, Isabel Smith, who you guys know well, who is the chair in autism research here. And then we partnered with my other supervisor, Dr. Jill Chorney, whose research focuses more on healthcare experiences. And at that time, her lab was doing a lot of work with the surgery unit at the IWK. And because this happens in a lot of research, in most of the studies, kids with autism were being excluded, right? Because of the heterogeneity of that. And the healthcare providers actually were saying, you know what, these kids keep getting ruled out of all of our research, and we really think it could be valuable and beneficial to include them in some way and to have some support around how do we enhance the care that we provide for these kids. And so that was around 2013. And so we had lots of conversations, and it became really clear we need more information and we need more perspectives to figure out what's going to be the best way to approach this challenge. And so we applied for some money to do a needs assessment. And at that point, we were able to connect with families who had children with autism have surgery at the unit, as well as more healthcare providers, and really talk to them about what's going on, what is it that you think that you need, and what would be the most helpful. And from that, really, it was guided by the healthcare providers and the families. They really felt like the priority was we need to develop a program for healthcare providers to help to enhance their ability to provide family-centered care for children with autism, right? Because everyone was recognizing that that's what was most important, right? Really partnering with families, figuring out what each individual as a unique person needs and adjusting our care to support them with that. Really collaborating well amongst the team, because I know you guys have had experiences with the day surgery unit. You know, there's lots of people, right, that come in and out the door. And one of the things that families shared with us is that they were having to retell the same thing to lots of different people. So we knew that this was a challenge, right? We need to find a way to help everybody to work together. And we need to support people to do that with lots of empathy and warmth, because it's a stressful experience for everybody involved, right? Regardless of whether you have autism or not, when your kid's having surgery, it's a difficult experience for people, right? And so that guided us to develop a program that we call Balance, Building Alliances for Autism Needs and Clinical Encounters, and the Day Surgery Unit Edition. And Macy, you know all about that because you were a star in the program. And your role, which was so awesome, was to teach the healthcare providers about what autism is. And then Amy, you did such a beautiful job as well, talking about the importance of family-centered care. And I know from the healthcare providers, they value so much more hearing that from you guys than if I was giving a PowerPoint teaching them about it, right? So that was really cool. So with your help and the help of some other families, we were able to build that program, along with some tools and resources that the healthcare providers could use to assist their ability to do that. So we called it the Take a Sec tool to evaluate. SEC stood for sensory, emotional, and communication needs, right? Which was sort of how they were able to individualize stuff. And then we rolled it out. We said, any healthcare provider at the day surgery unit that wants to do this, you're welcome to participate and do it. And 60% of them chose to, kind of in a voluntary basis. And like 85% of people who started finished the whole thing, which was awesome to see because it was quite involved. Yeah. And then what they told us afterwards was that it was really helpful for them. And they said it helped to improve their knowledge, it helped to improve their motivation, and it helped to improve their comfort delivering family-centered care to children with autism. They said that they were doing more things after the program that were consistent with delivering family-centered care. And then families noticed it too. So we also asked families before and after the program rolled out what they observed. And they said the families that received care after the program rolled out said, noticed more behaviors from the healthcare providers that were consistent with the delivery of family-centered care, which was really notable, especially because, to be totally honest, at our institution, we really value family-centered care, and there was already a lot of that going on, right? So for it to change enough that people noticed it from a baseline that was already pretty good, like people were working pretty hard, was really super cool. And so, yeah, it was a really awesome experience. Yeah.
From the family perspective on that, Stephanie,
Yeah.
we say that in another neat full circle kind of moment, after the program was rolled out to healthcare providers at the IWK, Macy's older sisters were in the day surgery unit for dental surgery, and we noticed it. We saw it directly in action within the way the healthcare professionals there approach things. And there was also one nurse who kept looking at me and saying, "You look so familiar." I can't quite figure out why. And it was because she had been trained by Balance.
Yeah, she recognized you from the videos. That's so cool. And I guess the other thing that I shared with you guys too, and we've chatted a little bit about Macy, what was really cool, which I didn't expect at all, is that it was so valued here that the hospital then took it on as kind of a project for themselves, and have since it's since been passed on to other children's hospitals in Canada. So I think like there's one in Quebec, one in Saskatchewan, and one in BC that all have access to this program now that can kind of support their healthcare providers. So you've had such an impact as a family, and it's been so cool to work with you guys on it. This is a really neat kind of coming back together experience that I'm glad that this Pursuit Award in Holland Bloorview allowed us the opportunity to reconnect. It's awesome.
Another question. How did your research end up helping kids like me and families like mine?
Yeah. Oh, so maybe I jumped the gun a little bit because, yeah, I think the way that it helped is because it really helped the healthcare providers to feel more comfortable and more confident and to know what was going to be the most useful. Yeah. And so just like we just talked about, I think that was so valuable for them. We had lots of really positive feedback. And then, like I said, it kind of took off from there and is now expanded to other hospitals as well. So I know, Macy, yesterday you were saying it's kind of daunting to think about, right? Yeah, that your face is there. Sorry, go ahead, Mace.
Oh, it really is.
Yeah.
It's something that in my 8-year-old brain thought was just a fun little video turned out to be such a grander thing.
Yeah, it's so amazing.
So many lives.
For sure.
It's
crazy. Yeah. So valuable, Macy. You did such a good job. And you were such a little star. You were a star even back then. I know we've talked about this, but is it okay if I share what you said?
Yep.
Yeah. So Macy did a little introduction for her video. It was so awesome. And Macy loves cats. And I just remember her saying, I remember your exact tone of voice. Like, "Hi, my name is Macy. I am a true cat lover. And I also have autism. And I'm going to teach you about it." And it was so awesome to see your personality and your spirit come across. And yeah, I know that the healthcare providers, like I said, they all commented on how valuable it was to hear about these things directly from the people that have the lived experience, right? So it's awesome.
Thank you so much.
So what does being a recipient of the 2020 Pursuit Award mean to you, Stephanie?
Yeah, I think it's just such a wonderful validation of the hard work that we all did and we put together. I think that it can be really challenging to do research that engages patients and families and healthcare providers in an authentic way, in a way that really informs the direction of care, because there's so many competing interests, right? There's time, there's what do researchers want the answers to, and I was really mindful, and I think everybody involved was really mindful that we really needed to ground our direction in the same way that the program was advocating for family-centered care. We needed to ground our direction in what is it that the healthcare providers and the families are saying is going to be most helpful for them. And that was challenging, and it required really dropping our research agenda and listening with open ears and getting creative and learning new research methods. And it's just so cool to have that recognized and valued, right? Because it's really important that if you're going to talk to people about what's going to be the most helpful for you, you really honor what that perspective is. And it's really neat to see the Pursuit Awards valuing that kind of family-centered research that really focuses on actually changing the day-to-day lives of kids that have various different developmental differences, right? So it's really kind of full circle for me, because I was saying that when I worked at camp, that was really kind of the thing that kept showing up for me. So it was really a humbling experience to get to this place, finish my dissertation, and have it be recognized by Holland Bloorview in this way.
Thank you so much, Stephanie. One more question. What are your plans for the future?
So as you know, I work now as a clinician, kind of a mental health clinician, and most of my work is direct clinical care. I'm still working on kind of publishing the results of the research in my free time, but I'm also always looking for opportunities in my role now to continue to advocate for how do we help healthcare providers, regardless of what their role is, whether it's on a physical healthcare team or a mental healthcare team, feel confident and comfortable providing care and services for all of the children and adolescents that might need our help and might need our services, right? So I have had some opportunities to help a little bit with some thinking about that. And in general, I'm still really motivated to always be working to improve the quality of care that we provide regardless of where I'm at, and really keep it focused on families and what it is that they need to feel supported and to be able to live their life to the best of their ability, so that they can do all the cool things that they're able to do. And I know, Macy, we were chatting yesterday about some of those things for you, which is amazing, right? Your set building and your mask building and all that stuff. So yeah, we want to help you to kind of be able to do that stuff if that's what you want to do, right? That's the goal, is for people to be able to live full and meaningful lives, regardless of whatever is, whatever their brain, however their brain is built, because diversity is important, and it makes our world richer.
Thank you so much, Stephanie. That's really important.
Yeah.
Stephanie, we are so proud to have been involved in this project, and we're so proud of you. So congratulations on this award. We can't wait to see what you're going to get up to next in your research and in the future. Thank you so much. Congratulations. And as a family, it is so wonderful to see family-centered care and family-centered research making real inroads, because this is the stuff that has a direct positive impact on our day-to-day lives. It has a direct impact on the healthcare clinicians. And it's really, really wonderful to see this blooming in these communities.
It feels hopeful, doesn't it? Yeah.
It does.
Yeah. Thank you guys so much for being such a big part of that. It's so awesome. Yeah.
And thank you for making us a big part of it and helping us.
Yeah, of course, Macy. Yeah, it's so important. Thank you for saying that, Mace.
Thank you, Stephanie. Thank you, Amy. And thank you, Macy. What a amazing interview. And I think it really speaks to the special nature of research in childhood disability. What other field would the researcher and the participants in research have such an amazing relationship? So thank you so much for joining us this morning. If anyone has any questions, we probably have time for just some very brief questions at this point. So there's one question that came in here. Aside from the video, were there other training tools that were provided to healthcare providers? And Macy, how did you decide what to say in the video?
Macy, do you want to go first?
Sure, I guess I'll go first. Basically, wait, which video?
The video we did. Do you remember? Yeah.
Okay. My brain is a little bit tired.
It's okay.
Well, with the first part, I guess I just kind of said what I felt like.
Yeah. Yeah. I don't know if the question is about our interview or about the video, like when you were doing the teaching, but do you remember the process that we kind of went through? It's okay if you don't. It's a long time ago.
I do.
Yeah.
I vaguely remember. My mother knows.
I remember it quite well.
Mom's got a vast memory and I've got like a little.
Yeah.
You were so small.
Yeah. What I remember is that, and this might jog your memory and your mom can fill in the blanks too, is we kind of worked together. And remember we had that whiteboard and I had my iPhone and I was filming you. Yeah. And we wrote out a script.
Yeah, that's the part that I remember, is writing in big letters.
Writing out the script, and then if she said something and she said, I wouldn't say that. I wouldn't say it like that. We'd rewrite it on there and come up with something that she would say. Yeah.
You gotta see through the branding.
The branding. Yeah. You show everyone your cat ears. I saw you had those out earlier. Those were really nice. Yeah, that's awesome. She had those on in the videos too, which was great. So I guess I'll answer the other part of the question is about the program. So the program had, it's kind of a package. And so it had a number of different components. It had about 7 e-modules that the healthcare providers could work through. And that consisted of the videos that included videos from Amy and videos from Macy, as well as videos from other families and from other healthcare providers talking about autism and principles of family-centered care. And then it had along with it activities for the healthcare providers to kind of reflective activities, essentially following adult learning principles to try to help them to learn those things, and case studies at the end that they each received strengths-based feedback on. And then simultaneously, we also introduced toolkits of resources to the day surgery unit that included some of the tools that we talked them about in the program, like the Take a Sec tool, which was about how do you assess individualized needs. And then it had ideas on the other sides for how to tailor care based on what you learned. And then it also had other resources that might support people to cope well in the surgery unit. So for example, if you found out that someone struggled with noise, there was a way to provide them with headphones so that they didn't have to maybe hear all of the noise in the unit. If somebody would benefit from fidgets or those kinds of things in the toolkit. So we tried to give the unit everything that they would need to be able to adjust care once they had assessed how they needed to do that. Yeah, I guess the other piece was champions on the unit too. So there was people that were identified that they could go to. So it was essentially an implementation intervention, if folks are familiar with that, and had a number of different components.
Great, thank you. Just one very quick question for Macy and Amy. You've had such a phenomenal role in influencing a family-centered research. Just wondering, what is the one piece of advice you would want to give researchers who are working with families in this field? What is the one thing you would want them to know and walk away with?
I think for me, one of the key pieces is thinking outside of the box. For so long, we've seen research and interventions focusing kind of just on the child and on corrective or theoretical things, when a child's life and a family's life is so much bigger than that. And there are other places that need to be addressed and targeted. So with Balance, that targeted the clinical professionals because they needed to know something in there. It wasn't the kids and the families who needed to know, it was the rest of the community, because we are part of that community. Kids with neurodevelopmental disabilities are part of the community. And so we have to start talking to the communities, to our education systems, to recreation programs, to clinicians, to everybody about how we can work together. And that is really deeply rooted on listening to what the actual needs, the concerns, the issues of families are. So that's the one thing that really, really is near and dear to me.
I would say the one piece of advice.
Give them Tim Hortons.
Give them. Give them Tim Hortons. Tim Hortons makes everything better.
Great.
It's easy as that. Tidbit, problem solved.
Yeah, Timbits.
Okay.
Problem solved.
All right, note it. Right. Thank you so much. Really, really appreciate it. I wish we had more time, but we do have to move on right now. So it's time now to announce the the winners of the awards. So each finalist's research was evaluated on the basis of academic excellence, potential for success as a researcher, excellence in knowledge translation, research productivity, and impact on childhood disability care. And again, we received incredible applications from around the world. And the finalists that presented this morning were those who showed the most remarkable promise. I'm pleased to present to you this year's recipients. In third place, receiving $1,000 is Dr. Kern Hertubis. In second place, receiving $2,000 is Dr. Victoria Sherman. And in first place, receiving $3,000 is Dr. Diane Mcdonald. Congratulations to all of our Pursuit Award finalists. And finally, to wrap up today's events, I would like to extend my most sincere thanks to everyone for being a part of the 2021 Pursuit Award ceremony, including our judges, distinguished guests, the award family, our award recipients, as well as all of you in attendance. Congratulations again to all of our presenters. Thanks for your dedication to the field of child disability. Thank you for the love and heart you put into science. I've certainly been encouraged by your presentations, and I'm sure many of us who have joined this morning, I can say the same. I'd like to thank Dr. Stephanie Snow, Amy, and Macy for joining us today. Stephanie, you continue to inspire. I was struck by your comment about publishing in your free time. I wish we could all be as good at doing that. And Amy and Macy, thank you again for your efforts to guide the research community towards developing interventions that really, really matter to families. On behalf of the Holland Bloor Review's Research Institute, we're thrilled to have the opportunity to recognize and celebrate the best in the next generation of childhood disability research with all of you. I look forward to celebrating with you next year at the 2022 Pursuit Awards. So thank you, everyone. I'm just going to turn on my applause here. And we asked the award finalists if you could just remain for a moment so that we could do a virtual photo for our records. So thank you all, and enjoy the rest of your day.